It's August 18th, 2017. We're in Chicago to do a living history interview of Dr. Patricia Kapur. I'm Dr. Selma, a retired anesthesiologist and past board member of the Wood Library Museum. Dr. Kapur and I have known each other since 1979, and I've watched and greatly admired her very successful career in many aspects of anesthesiology and its organizations. She's led a medical group practice and also been in hospital administration. We'll be learning more about her and her wonderful career and outstanding achievements in this interview. Dr. Kapur, let's start at the beginning. Where did you grow up?
Well, first I want to thank you, Selma. It's great to see you here today, and I appreciate the opportunity to share my experiences. I grew up in Syracuse, New York, where my family has lived for a number of generations. I was the most likely to succeed in my high school class. I think that set me off to see what I could accomplish in life. Mm-hmm. I then went to Oberlin College in Ohio, where I was a chemistry major. I didn't think about medicine initially. I had been influenced by a woman chemistry teacher in high school and decided to follow the path of chemistry. However, I became influenced by a female physician, wife of a physics professor at Oberlin, who was the director of a big public health project in Cleveland, and she inspired me to consider medicine as a career.
Uh-huh. And what did your family think about that decision, by the way? Was that something they thought you might succeed at, or?
I think they were supportive. I would say I was always quite an independent person, and worked my way through college with scholarships and student employment. And I think they were proud of what I was doing. There had been a woman physician in my family, a cousin of my father's, so there was a precedent. When she was attending medical school in Syracuse, she lived with my father's family. So I didn't have any familial obstacles to pursuing medicine as a career.
It was still a somewhat unusual choice at that time. This is just the beginning of the increase in the number of women physicians, so very interesting. Well, how many women were in your medical school class?
My guess is probably around 20 or so, give or take. The class was approximately 160, so that might have been 12 or 13% women, which meant 87 or 88% men. I may be off by a few, but it was a lopsided ratio in any event.
Right. What led to your interest in anesthesia? Oh, I forgot to ask, by the way, where did you go to medical school?
I went to the University of Pennsylvania for medical school.
Okay.
I know you're a alumni of their residency program, so yes. I was at Penn. When I was a first or second year student, Barbara Brandom, who subsequently became a faculty member in anesthesiology at the University of Pittsburgh, and I, out of curiosity, went and observed some surgeries in the operating rooms at the hospital at the University of Pennsylvania. I particularly remember being in a neurosurgical procedure with the big nursing table with the instruments over an open craniotomy case. So that raised my interest in anesthesiology. I was also considering gynecology, and I took a number of advanced electives in gynecology and anesthesiology, including extra electives in OR anesthesiology and obstetrical anesthesiology.
I see. When I was a resident at Penn, every medical student was required to rotate on anesthesia for 2 weeks, and we were expected to instruct them. So that program was gone by the time.
No, we all took an
rotated.
anesthesiology rotation, yes, to my recollection, although I remember as a student being left alone in the rooms at Philadelphia General Hospital.
Oh my gosh.
But that was the tenor of the times.
Right, yeah. And that rotation, the required rotation, was a legacy of Dr. Dripps and his power in the academic world at the University of Pennsylvania, I think. And then your choice of residency?
Well, that was a joint decision, I would say, as fate would have it. I married when I was a third-year medical student. My husband was a graduate student at Penn in chemistry. And then in the middle of my senior year, he started his career at Stanford Research Institute in Palo Alto. So I was behind in Philadelphia, finishing medical school, and my husband was already working in Palo Alto. At the time, when he made that decision, the obstetrical the obstetrical residency at Stanford had already made all of their decisions, and that wasn't an option for me. So Dr. Harry Woolman, the chair of anesthesiology at Penn, called Dr. Phil Larson, who was the chair of anesthesiology at Stanford at the time, and put in a word. And the short version is that I became a resident at Stanford in anesthesiology, coupled with an internship in internal medicine at Stanford. So that was a very happy outcome for me, and an excellent training program in anesthesiology.
Very good. And who was Dr. Larson was the chair?
Correct.
Bill Larson?
Correct.
Okay. And what was the department like then? Did you have lectures in anesthesia daily and also do cases? Or
I don't remember daily lectures, but it was a very vigorous program in my mind. We rotated not only through the Stanford operating rooms, but also to Santa Clara Valley Medical Center, where we experienced the social consequences of disease. It was a big trauma center and so forth. And we also rotated to the Palo Alto VA hospital. Dick Mazie was the chief at the VA, and Dr. Stansky and many other exciting and stimulating faculty members were at Stanford at the time. And I had a wonderful experience as a resident. I felt I was well prepared. They were doing heart transplants with Norman Shumway then, and we had many exciting cases.
How about research? Were you exposed to research through a rotation? Or?
We didn't have a research rotation, but many of the Stanford faculty were involved in research and publishing, and the VA, the Palo Alto VA, was also heavily involved in research. So that was a stimulus for me to remain in academic medicine. And I did talk to the faculty members there about what a research career in academics would be like. Dr. Larson personally was very encouraging about a future career in academic medicine.
And then you came to UCLA to be a research fellow, right?
That was another two-career choice. My husband was recruited to a company in Los Angeles, so he left again early while I was finishing up at Stanford. And then that's correct. I went and met with Dr. Ronald Katz, who was the chair at UCLA at the time, and then interviewed in the various research labs at UCLA, and came for it ended up being about 18 months of a research fellowship with Dr. Werner Flacke.
And were you in the main research lab area, or were you at the VA in their research labs?
No, I was right at UCLA. Correct.
I remember meeting you on your first day, and you were expecting. So,
yes,
how did that go?
That's correct. That's correct. Well, I had been, as I mentioned, married in medical school, so I was married for 5 years before we had our first son, and that was influenced by my perception that I needed to devote all my time and attention to my residency when I was a resident, and of course now things have changed, but there was only there were only 2 other women in the residency program total at the time, one in the class before me, and then another woman in my class. So I felt, and no one said this to me, but I just felt it wasn't a good option to take time off, and that I should continue and finish the program. Things are different now, but that was my perception then. So during the research fellowship was an opportune time because I wasn't assigned any night call during that time, so it worked out fine.
And what was your first project?
The entire time that I was working in the Flacca lab, it was a cardiac physiology lab, and Dr. Flacca had asked me to take a look at calcium channel blockers. Verapamil had just become available as an antiarrhythmic for human use, was approved for use, and no one had actually looked in great detail at the interactions between verapamil and inhalation anesthetics.
I see.
So projects that we embarked in involved an instrumented canine model, and we were measuring quite a variety of cardiac parameters when we administered verapamil during inhalation anesthesia, and identified the combined negative hemodynamic effects and potential for conduction interference and so forth. And so this information was sought after by the anesthesia community, so I very quickly received a number of invitations to speak about what we were doing. And Dr. Jerry Reeves, who was at Alabama at the time, I remember came up to my abstract at one of the meetings, and I was able to start the network that actually led to many of the anesthesia organizational opportunities that I had based on those research experiences. I mentioned getting to know people who were at Stanford at the time who were important in academics, but also the choice of the research topic that was on the forefront of knowledge for anesthesiologists taking care of patients with cardiac disease led to, presenting my abstracts, but also being on panels and attending other meetings to talk about what we were working on.
It's incredible what happens at meetings when you present and interchange that goes on with people that wander by, and very important piece of
I think it
what
is.
we do.
And I was at that early stage in my career afforded opportunities to meet many of the giants in cardiac anesthesia. Also, people who were reviewing my articles. I remember Bob Marin was a reviewer for the journal Anesthesiology, and Dr. Marin was extremely helpful. He seemed to be assigned most of my manuscripts to review, and he would write very detailed critiques of the articles that were extremely helpful to me to sharpen the manuscripts and make them as tight as possible, so to make the review, the subsequent reviewers' jobs easier as time went by.
Now, was this through anesthesiology or ANA?
Well, we were sending papers to both, but Dr. Marin at that time was a reviewer for anesthesiology, and I remember the reviews particularly that he would send that I think were very helpful. So, I mean, there weren't the subspecialty societies and the subspecialty society meetings in those days, so there was the IARS, the International Anesthesia Research Society meeting in March, and then there was the American Society of Anesthesiologists meeting in October. So the abstract submission dates were 6 months apart as well, so we would send an abstract in the spring for the ASA meeting and in the fall for the IRS meeting, and that was the cycle of presenting our work and getting the feedback from peers.
It's a great illustration of the role of reviewers of articles in terms of giving feedback about the development of projects and the analysis. So you were really very fortunate. It takes a lot of time to do reviewing, and we should really appreciate those people.
Especially for junior authors, I think it's so helpful.
So, very good. Well, how did UCLA compare with Stanford? Do you want to make any comparison, or you might not have gotten the clinical picture at UCLA?
Well, I subsequently spent my entire career at UCLA, so I think that research here got me off to a good start. And then when it came time to make the decision to stay on the faculty, at that time Dr. Katz asked me to start to work over at the Los Angeles VA, the West Los Angeles VA Medical Center. So I think from that point of view, the experiences I had at Stanford prepared me well for the career at UCLA, because I had done numerous rotations at the Palo Alto VA, so I had a good experience with VA medicine. And then shortly after I started working as a junior faculty member at the VA, the chief there, Dr. Jack Viljoen, left to become chair at USC. So Dr. Katz named me as the chief of anesthesia at the West Los Angeles VA at the tender age of 30. So that was another good experience, because I was on the Dean's Committee. I was responsible for not only the resident performance there, but the team of nurse anesthetists. So I had early formative experience working in a very positive way with nurse anesthetists, in that Stanford at that time hadn't had any nurse anesthetist on the team. So I learned to become an administrator. I learned to deal with a budget. I learned to wrangle equipment funding. And I learned to work with surgeon and surgeon colleagues and OR nurses, and it was a good thing that happened.
Right, a good basic orientation to running departments and being an effective administrator. So, in looking at your CV, you had so many activities, and what I wonder about is, how did you manage this all? Preparing for the many meetings that you attended, going to all the conferences and meetings that you had to go to. I found it overwhelming a lot of times.
I think that part of my point of view is that you have to give back to make your environment better, whatever it was. So I was interested in being involved in the professional organizations like the California Society of Anesthesiologists and the ASA, because that is the venue through which we communicate to not only our members but to the legislature and so forth. And Dr. Larson had us enroll as resident members of the CSA and the ASA on basically day one of our residency, which is something that we continued and did at UCLA. I would say the first thing that I started getting involved in was the California Society of Anesthesiologists. One of my mentors at UCLA was Dr. Stuart Sullivan, and Dr. Sullivan had been on the educational programs division of the CSA, which plans and organizes the California Society's multiple meetings during the year. So he was giving up his seat on the committee and nominated me to be a representative from UCLA. So that was how I started working with the CSA. Meanwhile, he also handed off the management of the UCLA CME annual meeting in Monterey. So through working with the meetings at the CSA level and at UCLA, I had the opportunity to invite speakers So I had the chance to invite many notable anesthesiologists to be speakers at those meetings and to get to know them. Again, with the hindsight, I can now see how some of those people that I met through organizing the UCLA meeting and the CSA meetings later opened doors for me in my career. So the CSA was where I got my start, and I was pretty much always involved in the CSA, and eventually was chair of the Educational Programs Division for about 8 years, and that put me on the board of the CSA, and I became the assistant secretary and then the secretary of the CSA, and for many years was a delegate from the CSA to the ASA. So the ASA committees and activities flowed out of that, starting, and I mostly worked in the education and research realms for the ASA, and was, again, if you want to be part of the solution, you have to participate. So I became chair of the section on education and research in the ASA for 8 years, which put me in an ex officio capacity on the ASA board, and then moved over to the annual meeting track, worked up through those committees, and became chair of the annual meeting for the 2008 annual meeting. So that was one, I would say, constant through the career. Then serendipity happened again in that I mentioned Dr. Don Stansky had been a fellow at Stanford when I was a resident. And Dr. Stansky, because I was working with the calcium channel blockers and I had my lab at UCLA continuing after I became a faculty member, named me to be one of the 6 permanent members, that may not be the right word, but the 6 3-year term members on the ASA Research Committee. There were ad hoc members who had 1-year terms, and then there were the, I don't know what's the right word, but the regular members, if you would, who had 3-year terms. So when Dr. Harry Bird and his colleagues were setting up the FAIR, the Foundation for Anesthesia Education and Research, as the ASA philanthropical arm to support research, they named the 6 3-year term members on the ASA Research Committee to be the first board of FAIR.
Okay, I was wondering how that happened.
So you can see a Stanford connection from a number of years previously led to my being one of the research committee members at the time that the first FAIR board was named. So that was a prestigious and important board to be on. I was on that board for 8 years and then president in the final year. Now the FAIR president is a permanent person, and I believe the board may have a chair, but at that time one of the board members was the president of FAIR, and we had an executive director more or less running the business. So that was
and that has become so important to anesthesiology, and so very successful. And you were there at the beginning.
Right, and those 8 years, of course, we had to define the mission of FAIR. We had to start all of the funding programs. We had to develop the industry partnership and the industry philanthropy. And it was great to be part of all those things.
Yes, yes, very exciting. So one of the things I noticed is that you crossed over organizationally to have a role also in the IARS, the second anesthesia organization. And people often think of these very separately, especially at that time. And do you have any thoughts? I mean, how did that happen?
I think it's the same idea where you never know what contacts and networks and connections will lead to something else. So as I said, I saw the CSA and the ASA as a constant throughout my professional life, and then the other boards that I were on had a life cycle, I guess I would say, like FAIR. 8 years was the term at the time. Well, actually, I think the terms were staggered, maybe 6 years, but some of us that started were segued into the longer number, and I was one of the 8-year people. So the IARS was interesting because I had been a cardiac anesthesiologist for the good part of a decade, building on, I was very comfortable with that casework when I was at Stanford, and then when I was at the VA, I did cardiac cases, and then after 3 years at the VA, I had returned to UCLA, and Dr. Denham Ward had been chief of cardiac, and Dr. Ward decided to join the general OR team. So there was an opening for a chief of cardiac. So when I came back to UCLA to be closer to the laboratory facilities and so forth, Dr. Katz asked me to be chief of cardiac. So I dropped into cardiac, and then when I was in cardiac, I thought, oh, we need to pay back. I became part of SCA. I was presenting abstracts and attending the SCA meetings, Society for Cardiac Anesthesiology. So, cardiovascular anesthesiology. At any rate, after almost a decade as a cardiac anesthesiologist, this is where one's life and one's career intersect, and one has to make decisions. And there was a particularly tight time when we were short of cardiac anesthesiologists, and the night call was very frequent. And I was having 2 call nights a week, first or second, getting home at 8:39 on second call, and 2 weekends a month. My children were already in bed by the time I got home. I left before they woke up the next day. It'd be 2 or 3 days before we saw each other. So at that time, UCLA was going to open a very large ambulatory surgery center in a separate building across the street, a fully outfitted new ambulatory clinic and proceduralist building. And there was an opening for a chief of ambulatory anesthesia, and this was in 1990. So ambulatory anesthesia was new. SAMBA had only been in existence less than a decade, and I volunteered to leave being chief of cardiac anesthesia, take over, set up, and establish this larger surgery center. Ambulatory anesthesia had existed at UCLA for a long time. I know you're aware, Dr. Dillon.
That's what I wanted to bring up.
Dr. John Dillon, the inaugural chair at UCLA, had expounded on the principles of ambulatory anesthesia quite some years earlier, but it was always enmeshed in the main OR with all the inpatients. So the efficiencies of ambulatory anesthesia weren't able to be achieved because the recovery room, pre-op, everything was mixed with the flow of the inpatients. So this was a new opportunity for us to start something, and it seemed like an exciting opportunity. So I don't want to say overnight, but it was quite an abrupt transition from cardiac anesthesiology to ambulatory anesthesia, and I experienced the joys and challenges of ambulatory anesthesia and realized that supervising multiple rooms with everyone expected to awake and leave in perfect condition could be very challenging. So at that time, shortly thereafter, so this is getting back to the IRS, the journal of the IRS is Anesthesia and Analgesia, and Dr. Ron Miller from UC San Francisco was taking over as editor-in-chief. Dr. Miller's vision was to have sections of the journal with section editors, and ambulatory anesthesia was one of the sections that he felt was integral to his vision. And we knew each other from the California scene and the California Society of Anesthesiologists, and I had been publishing in cardiac anesthesia. So Dr. Miller made the leap and convinced me that I would be able to use the same writing and editorial skills that I had been using vis-a-vis being an occasional reviewer on cardiac articles and writing my own to be, and he named me the section editor for ambulatory anesthesia in his inaugural editorial board. So that was very exciting, and it was also work because in addition to the ambulatory articles, he would assign me, of course there were many, many general articles that had to be reviewed, and I think one year I reviewed 133 articles.
Oh my gosh.
So that was...
That is tough.
2 or 3 a week, yeah. So it was a busy position, but what happened was that there was a crossover between members of the Board of FAIR and members of the board of the IARS.
Oh, okay.
So I had credibility with some members of the IARS board who are also members of the FAIR board because we'd worked together on the FAIR board, as well as credibility because I was a section editor of the IARS journal, Anesthesia and Analgesia. I believe those were points in the debate that must have been held as to who to invite to join the board of the IARS.
I see. I'd like to just mention one of your, I want to say famous articles on ambulatory anesthesia, the editorial about the quiet little problem that won't go away.
Yeah, the big little problem was the name of
about
the
post-op nausea and vomiting, and
yeah.
actually somebody mentioned that this weekend, so it lives on.
Yes, that was in the early 90s.
Right.
But I think that was part of the insights that I had from when I became an ambulatory anesthesiologist, that some things that were not high priority in the cardiac anesthesia, because in those days all the patients went to the ICU intubated and remained intubated for several days, was extremely important in ambulatory anesthesia. And there was an article from Dartmouth, from Fred Orkin, where showing that patients would rather have more pain, more discomfort, more whatever, if only they didn't experience nausea. So I realized that anesthesiologists were being judged harshly if we were not able to resolve that problems, and patients went home and told their friends and family that they had a very poor experience.
And this is what led to ondansetron and all the other antiemetic drugs eventually, right?
Yeah, I don't know if it led to it, but I think it validated the people who were working on these problems and who were attempting to find better solutions for us. Yeah. I don't know that it changed what pharmaceutical companies were doing per se, but you're right insofar as we subsequently had more options to look at, and people were creatively combining
and I remember lots of articles on this, you know, how to try to treat this.
Right.
So what was it like being a leader, one of the few women in this time period in anesthesia? Were there many women? No, there were not. But I think my approach was to be as absolutely competent as I could be, and to work as hard as I could, and to support the goals of the organization, whichever was the one I was working on, and try to have good outcomes as far as the educational goal goes. The IARS had only one woman board member prior to me in its entire existence since 1922. And then subsequently, when I became a director of the ABA had only had 2 women directors before me in its existence since the 1940s. When I became chair of anesthesia at UCLA, I don't believe there had ever been a woman clinical chair. That have been women chairs in basic sciences, but not in clinical departments. I'd have to look back. I was the section
chief for education and research in the ASA. I don't know if there's been any women previously. There have been subsequently, and I was chair of the section on the annual meeting, and I know there may have, I'm pretty sure there were some women before me. You might know better from your research. So there were, it was a lonely, a lonely place to be, I would say, but my friends and colleagues were the male members of the board, and I think I was always treated fairly, and I think my contributions were respected and taken seriously.
Mm-hmm. Very good. And how about childcare, Patricia, when your kids were smaller and say you were on cardiac call, how did you manage that?
Well, my husband had a busy career. He, as I mentioned, had a PhD in chemistry, and when we were in Los Angeles, he worked for an R&D company and then subsequently owned his own R&D company. But, and he was also a journal editor for the Journal of the Electrochemical Society, so he was presenting at meetings and also editing papers. So we had agreement among ourselves that we would be supporting each other's careers. So we did not go to each other's meetings because we wanted to have one parent at home.
Okay.
And we took the children out for childcare to a home daycare situation till they were old enough for preschool, and then they went to preschool, and then you know, elementary school with a after-school program. So my husband took the children to daycare, preschool, elementary school, and then generally I picked them up, except when I was on call, and then he picked them up also. When they were in junior high and there wasn't an after-school program, we had a woman in her 60s or so, I would say, whose family was already grown, and she had a key to her house, and she would come over at 3:30 and stay in the house until one of us got home. So, and then as soon as they got to be 16, we taught them how to drive, so that, and we had a used car so that they could drive themselves to high school.
Very good.
Yeah.
You know, I remember when you were the head of UCLA outpatient surgery, there was a time when some of the women doctors needed to leave early, and there was conflict about whether they would be able to go, and the pressure on the women who wanted to leave was coming from some of the other women. And I thought that was an interesting twist. And I don't know, it seems to work pretty well nowadays, and the use of nurse anesthetist has smoothed out some of this.
I think there are various schedule options, and at least in academic centers there are late shifts, and there are options of people to be assigned or volunteer to stay late. There's more recognition that family impacts men and women.
And this is so different from earlier times where you did your case, you know, to the end, no matter what time it was. Well, what do you think is your legacy to anesthesiology? Have you thought about that at all?
I think the one of the important things motivating me is, as I said, to be credible so that the door stays open for the next women who want to pass through. There are so many women now involved in all of the organizations. It's very exciting. There are lots of women on editorial boards. There are lots of women in leadership positions, and the pipeline is very rich. Medical schools are 50% or more women, and I think there are very few obstacles now to whatever women like to do. And I think we have to be open to different choices for women. Some people want to be as involved as I was, and I was fortunate to be able to do because my family life was supportive of the accomplishments. Others want different mixes and matches of family and career, and I think we should make room for everyone and what they would like to do in their life and in their career.
Right, and this changes over time. When my children were grown, then I could devote much more time and attention to academics. It made quite a difference. So.
And you were one of the people who inspired me as well. You may not remember, but you mentioned that we met early on in my career when you were a faculty member at UCLA. And we did have a chat where you told me how academics was could be a good choice for family and career because of the collegiality and teamwork that are present in academic practices. I'm sure private practices experience some of those same qualities.
When I was in private practice before coming to UCLA, it wasn't teamwork at all, and so coming to UCLA was very different, and that's one of the things that I really love about anesthesia today is it's very much team. And after I retired, I'm actually dreaming about our team working together and having it all come with a positive outcome for patients. So
and I think I didn't these reflections on being a woman in this scenario was not something that was close to mind when I was busy with all these organizations. I think I saw myself as a team member with everybody else on these boards and accomplishing things for the ASA and the other organizations. I had so many wonderful colleagues, and APSF was, I was talking about things having a time and place in life, and I also had some very wonderful experiences working with Dr. Stolting and the APSF board towards the end of my time. So there's many opportunities for anesthesiologists to become involved and participate.
Yes, and I think in the early days when I was going into anesthesia, like 1966, it was very different because of the few women that were around, and they stuck out, I want to say, a lot more, and it was just a different time. So, now you gave the Rovenstein lecture in, I believe it was 2015? 2011.
Yeah.
And you discussed the need for anesthesiologists to move into hospital systems and contribute to the entire perioperative process. And how do you think we're doing? That effort has been going on for some time, and are we moving appropriately, do you think?
I think we're moving in the right direction. The current ASA leadership can describe better than I how we're doing. But I saw movement when I became chair. One of the things that was critical to me was to be involved in OR management, because the surgeons would come and go, and any particular surgeon might be in the OR 1 or 2 days a week, some of the busier ones multiple days. But anesthesiologists were in the OR every minute of every hour of every day, and if the OR wasn't managed efficiently, and if the cases weren't allocated in a wise manner, resources were expended unnecessarily, time is money, etc. So over the first few years of my chairmanship, we got involved in OR management now. There are anesthesiologists active in all the OR suites at UCLA. In the administration, we built bonds with the OR nurse administrators, with the surgical leaders, and so forth. And I could see that happening in many other hospitals as well. So I assume that anesthesiologists, for the same practical reasons I was interested and motivated, are seeing that in their hospitals also, to step up and contribute to leadership. Getting involved in the practice group was also key when I was chair, because we would get paid. There are HMOs, Health Maintenance Organizations, active in California that would give a package price for the care of a patient. And at the time I became chair, we were allocated a very small unit value for that HMO work that was decided by the finance committee of the practice group. So the first thing I did, or very early on, was become a member of the budget and finance committee of the practice group and the managed care and contracting committee, so that we would execute good contracts with insurers, and we would allocate the money fairly to everyone who was contributing to the patient's care. So stepping up and getting involved in those key committees led eventually to me becoming the leader of the UCLA practice group by a series of progressive steps. And then in the end, I was president of the practice group and executive vice president of UCLA Health, were the titles that I held. So it is important for anesthesiologists, in my view, to get involved in healthcare leadership and to solve the problems, and particularly as the payment system go more to bundled payments or payments for keeping patients well and intervening early on. It's important that we step up and get involved in every way that we can help accomplish that goals, because I could see that joint pots of money can be divided well or poorly, and to be part of the value proposition and show that we're making a difference in enhancing the value of the funding, we need to make those contributions, whether it's ICU, pain, OR management, patient throughput, outpatient success, whatever.
Anesthesia is a highly technical specialty, and technology is changing. Actually, the changes are accelerating. And how is that affecting what we do, and especially things like ethics, the care of, say, a patient that has a low chance of recovery?
Well, I think definitely the advances in technology, surgical and anesthesiology delivery systems and monitoring capabilities have allowed us to take care of much more ill patients than we would have previously. And I started my residency back prior to pulse oximetry, prior to capnography, and we were prior to infusion pumps. We were counting drips and albuterol to give medications. And we were timing bellows in ventilators and things like that. So I have been able to see most of the recent important advances. So I think the monitoring, particularly the development of ultrasound now for us, there's a call for anesthesiologists to become even more versatile with ultrasound, not only for line placement, regional block placement, and so forth, but to do some of the rapid scan diagnostic for pulmonary complications, not just cardiac complications, DE, pulmonary complications, abdominal issues and findings, and so forth. So I think that will happen and will make us more versatile. That will also extend our usefulness in the perioperative surgical home, that we can be someone who can help prepare the patient for the surgical experience and help care for them after the surgical experience. I think the tele-ICU capabilities, where we can have a person in a base station supervising patients and caregivers remotely, allows us to take care of patients closer to home, bring those that really need it into the higher level hospitals, and so forth. And also those techniques may be extrapolatable to PACU supervision, pre-op evaluation, even OR supervision. So I think our lives as anesthesiologists, or the future anesthesiologists' lives, will be changed by these technologies, but I think we should embrace them and enable more things to be done. Obviously, surgical advances too, such as the number of cardiac procedures we can now do in interventional labs and so forth have affected what we do, but again, sicker patients. On the ethical realm of whether or not these procedures should be done, that can now be done because of better surgical technology, I think we're more likely to have a seat at the table if we participate in more aspects of care rather than just the procedure itself. I know at UCLA, some of my colleagues there who have gotten deeply involved in the delivery of intensive care medicine are participating in palliative care, end-of-life counseling with families and so forth, and particularly with patients in tertiary quaternary hospitals who are facing very difficult decisions to proceed or not. It's great to have the perspective of the anesthesiologist be part of that discussion. So I think that is another way we can contribute to good healthcare delivery, but only if we're willing to be part of the bigger healthcare system.
What drives you to love anesthesia, to commit to this specialty, and continue to strive for better patient care? Young people who might be interested in anesthesia would be interested in your answer, I think.
Well, I think it's twofold. I think one is the science of anesthesiology. I mean, I joke that anesthesiologists open more ion channels per millisecond than anybody in the hospital. You know, our medications are manipulating physiology very rapidly and in real time. We're clinical pharmacologists, we're clinical physiologists, we're manipulating all the organ systems, acid, base, endocrine, everything in real time. And medicine isn't an exact science, I think those of us know, so we make a hypothesis about every patient, that this patient has a poor ventricle and therefore we have to prevent suppressing the sympathetic nervous system unduly and so forth. And we start out with that hypothesis and we give a very careful anesthetic, and then the patient's blood pressure shoots up. You know, the hypothesis is disproved. This patient has a vigorous response. We need to suppress sympathetic reaction so that the patient won't experience cardiac distress. So I feel that I'm taking all my knowledge about the patient, putting together a hypothesis and then executing on that scientific plan, but I have to be constantly willing to readjust it. And it doesn't matter whether it's a cardiac patient or an ambulatory patient. I had my malignant hyperthermia case of my life in the ambulatory surgery center at UCLA, full-blown pH 7.14, and then we gave dantrolene, and within a few moments the pH was 7.34 again. In all my life I've never seen someone be so acidotic and so miraculously treated as that patient. So wherever I have been giving anesthesiology, I have a profound respect for the variety of reaction of the human physiology. And every day is interesting. So I think there's that. But I think the other human aspect is that we have the privilege of taking care of patients when they're facing some of the most vulnerable experiences of their life. A patient might have one or two, or if they have 3 surgeries in their life, it's a big deal. And we're taking care of multiple patients in a day. It could seem to be a routine, but that ability to reach out to patients and engender their trust that they would turn over their whole essence or that of their child or their beloved parent to us is a privilege. And to be able to see that through in real time and the results available the same day, at least the initial results, the preliminary results, is a very exciting thing to do. And I think these opportunities in the broader healthcare system will enhance the pleasure and satisfaction of being an anesthesiologist.
One of the issues for us in anesthesia, especially being involved in operating room care, is the need to produce, make decisions very rapidly, deal with multiple requests coming from various people. And there's a lot of stress, time stress, that some people are uncomfortable handling. How did you feel about, or what was your way of handling all the multiple demands and the time pressure that come to those of us who work in the operating room and also have an academic career?
That's a great question. I think it affects everyone.
Everyone.
Yes. I think basically I am a very positive person, and I took a very positive can-do attitude. I wanted to do all of the things that I did. I didn't feel that any were imposed on me. And as I said, my husband and I were supporting each other in our careers. So I think that's important. I think if you don't have the mental and moral support at home, it's very difficult. Man or woman, the family has to be supportive. And I remember when I was the section editor of Anesthesia and Analgesia, and my name would be at the top of the beginning of the section. And I remember one time showing my son, I'm proud of what you do at school. I hope you're proud of me. And I think they all were, and my family did come to the Robenstein lecture and so forth. But I think one does have to be incredibly organized. I think I had good team members at UCLA, wonderful colleagues who were the OR chiefs and the service chiefs and the vice chairs and so forth at UCLA. The other people who worked with me in the practice group and in the professional organizations, whichever, were all terrific. So I think that I never felt alone in any of the things I had to do. One can't do the work at one's job and the professional societies in an 8-hour day. So I think that if one wants this type of career, one has to be willing to put in extra time. And as I said, I felt to keep the door open for the people behind me that I needed to really do the best I could. So for example, when I was reviewing the journal articles, I would get up on Sunday, I had about 2 to 3 a week, whatever. I would get up on Sunday morning, my husband and son slept late, and from 5 to 10 I would put in 5 hours, 2 or 3 hours apiece on the journal articles doing that. I would wait till the family was in bed and I would work on my committee work for the organizations and so forth. I think that there's no time that's too short that you can't fit something into it. When I was a department chair and so forth, even half an hour, I had things lined up that needed attention and I would work on that. And in your personal life, you have to be willing to delegate as well. I had a wonderful housekeeper who was with me for 34 years. We paid for gardening work and all these type of things so that when we were home, we were spending the time with the family. So I think one does have to think it out and pay to have things done at home that don't require your work so that you can devote the time to the family. Reserve family time for the children and things like that is inviolate, that you spend together. You know, my husband got home late, so we always ate dinner late because we wanted to have a family dinner, things like that. So it was challenging, that's the truth. But it was something I wanted to do. I had the support at home. I allocated my time, hired great people to work with me. The committees and the organizations had great people, and it worked out.
Anesthesiologists have so many responsibilities, especially as we advance and take on more and more. And Dr. Kapur reminded me of a resource that she found useful, and I have found useful also.
When I was a young faculty member at UCLA, and Selma was one of the many people that I talked to about balancing everything in one's career and life, and she recommended a book to me called How to Gain Control of Your Time and Your Life. And that was the period when I was a young cardiac anesthesiologist, had a young family and all of the call responsibilities. And it was very helpful to me. And the thing that I remember is sorting obligations into the things that one has to deal with right now or today, the things that can be set aside for later in the week or next week, and then the things that one probably can ignore and not have to deal with. And the gist of it for me was putting one's efforts and energies into the high priority things, whether it's for the family or for home. And even later on, when I was a department and health system executive, my assistants would sort the things coming into the office for me into what I needed to look at by the end of the day, what I could look at in the next couple of days, and what I could probably ignore or they could take care of. So it was very handy, and that focus on the most important things and the things that matter for the family's well-being, the department's well-being, the patient's well-being was something that did help me throughout my career. So thank you, Selma.
Great. It really helped me also. So, is there anything else you'd like to say, Trish?
Well, I think that anesthesiology is a great profession, and I think that we do have these opportunities to contribute to the well-being of our patients and the health systems of which we're a part. And I would hope that everyone would get involved at whatever level they can get involved, whether it's with the state and national societies, subspecialty societies, hospital medical staff, practice group, whatever, that everyone will choose the way that suits them to be part of the solution.
Well, thank you so much for such a wonderful, wonderful interview, and I hope that a lot of people will see this video and learn about your many accomplishments and how you did them, and also the many contributions you've made to the specialty of anesthesiology.
Well, I've enjoyed the interview. Thank you very much.